Hi, good morning, everybody. Um, Welcome to our next ATS Journal Club webinar. I am really excited to have this distinguished panel with us today to discuss the new ACC, AHA, ACCP, CHEST, ACEP, SKY, SHM, SIR, SVM, and SVN guidelines for the evaluation of management of acute pulmonary embolism. It was really not very hard to put this panel together. So thank you everyone for your enthusiasm to join us for this. I will start with a brief introduction of the panelists. So I have Dr. Giri, who's an interventional cardiologist at the University of Pennsylvania and co-vice chair of the guidelines, Dr. Parth Rali, who is an associate professor at Department of Thoracic Medicine and Surgery at Temple University in Philadelphia. He was on the review committee of the guidelines. I have coming all the way from Spain, Dr. David Jiménez, who authored the prior ESC ERS guidelines, respiratory physician at Ramon y Cajal Hospital in Madrid. Belinda Rivera, Dr. Belinda Rivera, coming from Pittsburgh, professor of medicine in pulmonary critical care. And then Dr. Vic Tapson, who's a faculty at Cedars-Sinai, who chaired the first set of ATS guidelines in 1999 and is now a VP of Medical Affairs at Inari Medical. So welcome, everybody. My name is Maidah Yaqoob. I'm an assistant professor of medicine with pulmonary critical care at Cedars-Sinai Medical Center and a PE enthusiast as well. So we've had a little bit of technical difficulties to display our slides here, unfortunately. So please bear with us on that. But the main core part of this discussion is really the discussion with all of the experts, since we have all the great minds here. So we'll go ahead and get started. All right, so I wanted to start with a very brief case, and we'll try to come back to it at the end of our discussion. So this is hot off the press. I saw this patient on Friday as a 40-year-old female with past medical history of fibroids complicated by abnormal uterine bleeding, had a prior DVT and PE with a history of non-adherence to her DOAC, stopped 2 months into treatment. This was 3 months ago. She was started on Provera for her abnormal uterine bleeding, had several admissions to the hospitals in the meantime with anemia requiring frequent blood transfusions, and this time presented to us with shortness of breath and fatigue. Her initial vitals, she was tachycardic in the range of 100 to 110s. Her respiratory rate ranged from 24 to 32, blood pressure being normal at 127/99 and saturating 90% on room air. Her labs were significant for a hemoglobin of 7.5, with her baseline being around 8. Normal platelets, had a mild AKI with a creatinine of 1.1 and a GFR of 65, and had an elevated lactate at 4.2. Her high sensitivity troponin was normal at 16, and her BNP was 2000. On her scores, she was a PASI score of 80 points, categorizing her as low risk, SPASI score of high risk, and a Hestia of more than 1. This is her CT scan. And you can see a saddle embolus there, extending into bilateral lobar and distal pulmonary arteries. Her RV to LV ratio was elevated at 1.8, and she had a borderline pulmonary artery size. And on her parenchymal view, which I haven't included here, she had patchy ground glass opacification with some concern for infarctions. An echocardiogram was performed. We can go to the next slide, which showed mildly dilated right ventricle with moderate to severe depression in the systolic function, a normal EF, mild to moderate TR, and an estimated PASP to be elevated at 55. So we'll put a pin in that and come back to it. But I just wanted to go over some of the highlights of the current guidelines. This by no means is a comprehensive overview of the guidelines. I would refer the listeners and the watchers to refer to the guidelines, peruse them at your leisure. But I will be talking about a few of the salient features that just stood out to me. So risk stratification, anticoagulation considerations and recommendations, and then recommendations about the advanced procedures and post-PE care. You can go to the next slide. So, as you all know, that the stratification of PE has evolved over the years. In 2011, AHA categorized it as low risk, submassive, and massive. And thereafter, in 2019, the ESC guidelines categorized them into low risk, dependent on a non-elevated risk score, intermediate low risk score, where you have an elevated risk score plus none or one of either troponin or right ventricular dysfunction on imaging, intermediate high risk with an elevated score, positive troponins, and also positive right ventricular dysfunction on imaging, and then high risk where you had all of the with hemodynamic instability. The 2026 guidelines, the recent guidelines, categorize PEs into 5 categories that are further subcategorized based on the hemodynamics, biomarkers, and imaging from A to E, where us as Parth will usually get called for patients who kind of are in the C to E, depending on your institution and your practices. We will often get called for B as well. And there's also an addition of respiratory modifier that can be applied to these patients if patients are hypoxic or tachypneic. So this is the figure that we're going to be seeing a lot, and you can see that A is defined as subclinical. So these are the patients that you just had a CT scan and you incidentally found a PE. They're basically asymptomatic. Patients who are in B are symptomatic and they have a low clinical severity score. And there's a really nice table in the guidelines where you can look at all of the various severity scores that you can use and what their utility is. But B1 is patients who have subsegmental PEs with single or multiple, and B2 are non-subsegmental PEs. Group C is patients who are symptomatic and have an elevated clinical severity score. In C1, just to make this more granular, they've been divided into C1 with normal RV and normal biomarkers, C2 with abnormal RV of more than 1 and abnormal biomarkers, and C3 more abnormal RV with more than 1 abnormal biomarker plus minus respiratory modifiers, as we talked about earlier. D is patients who have incipient cardiopulmonary failure, and patients could have transient hypotension and normotensive shock. This was actually very nice to see in the guidelines because we do have a lot of patients, such as this patient I described, who have a normal blood pressure, and you wouldn't think of getting a lactate, but now based on these guidelines, hopefully people will get a lactate and realize these patients have normotensive shock, and that puts them at a higher risk. And then finally, E with cardiopulmonary failure, in which E1 is patients who have recurrent or persistent hypotension with cardiogenic shock, and E2 are patients with refractory cardiogenic shock or a cardiac arrest. And you guys can see that the respiratory modifier are different for each of these, where the amount of oxygen is increasing as you sort of go down the risk. This is a very nice figure that kind of puts all of the management together, looking at all of the different considerations of these guidelines, including the choice of anticoagulation, when you should be measuring lactate, which is from C1 onwards, multidisciplinary PERT involvement from C1 onwards, evaluation of RV size, to consider ECMO when patients are in the E2 category, and use of advanced therapies and invasive therapies. So just a little bit on the anticoagulation therapy. So there was a class 1 recommendation, just to be very brief about this, class 1 recommendation to treat these patients with anticoagulation. The choice was low molecular weight heparin over unfractionated heparin to reduce the risk of VTE and major bleeding. And then if patients were eligible for oral anticoagulants, a class 1 indication to choose DOACs over vitamin K antagonist. There was a class 2A recommendation for patients who were in category C2 or higher, in whom the bleeding risk is low, to start anticoagulation when imaging was delayed or not immediately accessible. The next slide. And special considerations, which I appreciated, was the mention of patients whose BMI was more than 30, and the fact that DOAC would be considered preferable over VK antagonist in this patient population. And in patients who had a class 3 obesity with a BMI at more than 40 and acute PE who were receiving low molecular weight heparin, to reduce the dose of low molecular weight heparin to reduce the risk of bleeding. Next slide. There's a mention of antiphospholipid antibody syndrome, where patients who have established antiphospholipid antibody syndrome to choose VKA antagonists in preference to DOACs. But if the patient had single antibody, then a DOAC might be reasonable. Also mentioned was primary or metastatic brain cancer, where these patients who are otherwise eligible for oral anticoagulant, it was a class 2B recommendation to consider a DOAC over a low molecular weight heparin to reduce the risk of intracranial hemorrhage.